It's great to have so many folks joining us today for our forum with the Cabinet for Health and Family Services. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health and a member of the ThriveKY campaign. Many of you have joined us for these forums, which we hold about quarterly for many years. But if you're new to our forum, welcome. We're glad to have you. This year has continued to fly by. Our last forum, I believe, was in May, and it's suddenly back to school season. So I hope that the year is off to a good start for everyone. And why don't we go to the next slide, Alex? Again, for folks who might be joining us for the first time, if you're not familiar with Thrive Kentucky and the work that we do, our mission is to meet the basic needs of every Kentuckian through systemic change, because we recognize that many of our fellow Kentuckians and our neighbors have faced historic barriers to just their basic needs, to the public assistance programs and other resources that they need to thrive. You can see the principles that guide our work on this slide. And I recognize it's a lot of words on a screen. Don't feel like you have to read everything now. You will be getting these slides and the recording as a follow-up. So you can take a closer look whenever you get these in your email. We can go to the next slide. If you're curious about who's part of Thrive Kentucky, here is the list of our members, the organizations that we partner with. And if you're interested in learning more about one of these organizations, all of these are hyperlinks that you can click on. Let's go to the next slide. We always like to thank our sponsors for supporting this work, Humana Healthy Horizons and the Primary Care Association. This helps us to provide webinars like this at no cost to our network of advocates and boots on the ground folks who are serving your communities every day and making sure that people have the things that they need to live and to thrive. And if you are interested, if your organization is interested in sponsoring Thrive Kentucky, either for the remainder of this year or maybe next year, reach out to us. Kelly and Alex from our team at Kentucky Voices for Health can give you more information, and they can put their emails in the chat. And why don't we go on to the next slide? This is our schedule for Thrive for the remainder of the year. You can see all of the various meetings and sessions that we've had so far crossed out, and then the ones remaining. So we have some additional roadshows coming up where we do this more intense 3-hour presentation covering different aspects of our safety net, resources that can be helpful to the work that you're doing in your community, along with some advocacy training. And we love visiting different parts of the state and really getting to understand, what's working in a community, what may not be working so well, and how we can work more closely with communities to advocate for policy change. So definitely take a look at that list of different locations, and then we'll have some additional webinars as well throughout the year. And we always end the year with a virtual roadshow for anyone who wasn't able to make it in person. We can go to the next slide. This is the agenda that we're going to be covering this morning. I think I mentioned we held our last forum in May, and since then, Congress has made major changes to some of our largest public assistance programs, which means that we have a lot of catching up on those to do today. We've also had a change in leadership at the Cabinet for Health and Family Services, with Dr. Stack taking the helm as secretary in July. And this morning, we're excited to welcome Deputy Secretary Tricia Okeson and the Department for Public Health Commissioner, Dr. Langfeld, joining us for the first time this morning. So very happy to have you all here. We're also delighted to have joining us this morning Medicaid Commissioner Lisa Lee, Medicaid Senior Deputy Commissioner Veronica Judy Cecil, Medicaid Deputy Commissioner Dr. Leslie Hoffman, Department for Public Health Deputy Commissioner Dr. Connie White, Division of Health Plan Oversight Assistant Director David Berry, Department for Community-Based Services Commissioner Lisa Dennis, Director of the Division of Family Support Roger McCann, Department for Aging and Independent Living Commissioner Victoria Elridge, and I believe that we may have a couple other folks joining us as well, who I don't have on my list, but we will get those names to you very shortly. And as always, our goal with these forums is to create more open dialogue between cabinet leadership, consumers, and advocates. And we really want these webinars to be an opportunity for you to get updates on any changes to our safety net programs, share feedback and ask questions. So we appreciate when people just put questions or comments in the chat as we're going along. During each section, don't feel like you have to wait until we're at the end of a particular section to just pop something in the chat, and we try to get to those as we go. And just before we begin, a little bit of housekeeping. We have a lot of folks on the webinar today, so please be sure to mute your line. We're also recording this webinar. We'll be sending out the recording along with any materials and an evaluation and a follow-up email. So you should be getting that sometime tomorrow. And if you're a certified community health worker or a social worker and you'd like to receive CEUs for attending today's webinar, please be sure to complete the evaluation. That's the only way that you're going to be able to get those CEUs. And that's another benefit of our sponsorships, being able to cover those CEUs for free. So with that, I am going to turn it over to Dustin to get us started with some federal updates.
All right. Good morning, everyone. My name is Dustin Pugel, and I'm the Policy Director at the Kentucky Center for Economic Policy. And we wanted to start today by kind of walking through some of, not all of, the changes that the One Big Beautiful Bill Act, H.R. 1, the Budget Reconciliation Package, made to many programs that folks on this call really care about and work in and want to make sure are operating to the benefit of all Kentuckians. I don't think it's an exaggeration to say that this bill was the most significant change to Medicaid, certainly, since the Affordable Care Act 15 years ago, and is the most sweeping set of changes to our safety net, probably since the 96 Welfare Reform Act. These changes are really in the form of many types of deep cuts. Those cuts are really packaged in particular policies, and while I think it's safe to say that there will be a significant impact on the state, that doesn't mean that there's nothing to do now. The state has a lot of latitude for implementing these policies, and a lot of decisions are going to need to be made starting now, but certainly into the future as well. So part of our hope today was to hear from some of the folks who are going to be wrestling with and implementing a lot of these policies. It is, I should say up front, believe it or not, we're still in very early days of this policy. Some of it is not even being implemented yet. And so there's a lot that we can't say, but our hope is that at least we'll have some snapshot of what's to come in the coming months and years. So I want to start today with some conversation around Medicaid. And we have Commissioner Lee with us today to discuss some of this. And I wanted to start with some of the cabinet's plans around and maybe a timeline for the new work reporting requirement that is required by the One Big Beautiful Bill Act. The implementation is not supposed to start until next year, but obviously there's a lot of work to be done in the meantime. So Commissioner Lee, can you tell us a little bit about what the cabinet's plans are moving toward that, and maybe what some of the goals are around designing a program that meets those requirements?
Certainly, and thank you so much, Dustin. I'm sure many of you may know that prior to House Resolution 1 being passed and put into law with signature on July 4th, the Department for Medicaid Services submitted an 1115 waiver per House Bill 695. We submitted that 1115 waiver to the Centers for Medicare and Medicaid Services, or CMS, outlining our plan to implement community engagement requirements as required in House Bill 695. So after we submitted our 1115 waiver, House Resolution 1 was finalized, and we know now that our waiver that we have submitted does not conform to the requirements outlined in House Resolution 1. So our plan for our 1115 waiver for community engagement included extending our partnership with workforce development, whereby we allowed individuals to check a box, basically saying they want to be connected with resources to help them gain employment. So that was all optional. Individuals could choose to opt into that. And based on House Bill 695, it was going to be a mandatory requirement. And then House Resolution 1 does indicate that eligibility, Medicaid eligibility, has to be contingent upon individuals meeting those community engagement activities. However, our waiver did not make eligibility contingent upon that. So now we are in a position where we have a pending waiver with CMS that we know does not confirm or conform to their requirements. So we are in communications with CMS to see what our options are going forward. We know we will have to amend our waiver in order to be in compliance with federal rules. And as we think about what we want to do, we definitely want to strengthen that partnership with workforce development because they are a key partner in connecting individuals with employment opportunities. We also will need to make major system changes to our eligibility and enrollment system. For example, we'll need to make sure that we know how many individuals and who will be required to complete community engagement activities, because we do have exemptions. For example, anyone who is being treated for substance use disorder would be exempt. And I would also like to point out that the community engagement activities are only going to be applicable to Medicaid expansion members. Those are individuals who are between the ages of 19 and 64 and who are at or below 138% of the federal poverty level. So in the meantime, we're still waiting on guidance from CMS, but what our goals are is to ensure that we remove any barriers to reporting, that we are able to demonstrate in our system as much as possible that individuals are meeting those community engagement activities, because our overarching goal is to definitely ensure that every individual who qualifies for Medicaid remains in the program. So we'll be doing everything we can to make sure, again, that reporting mechanism would be easy to do, various sources. And also, again, the state would be using every resource at our disposal to ensure that, number one, that we are confirming that individuals comply with those requirements so they can maintain their Medicaid eligibility.
Yeah, in some ways, the waiver that we submitted was fortuitously timed because it actually provides some degree of job placement assistance for folks who may be in a difficult spot and wanting to maintain their coverage. So I'm glad it worked out the way it did under the circumstances. Can you tell us a little bit about sort of what we're anticipating in the out years related to the changes in Kentucky's Medicaid provider taxes and also our, what is it, 4 or so state-directed payment programs?
Sure. As we move forward, Kentucky has a couple of supplemental or directed payments. And basically what a directed payment is, we have a couple of provider types. For example, hospitals are our major provider type that benefit from directed payments. We also have ambulance providers who benefit from directed payments. And essentially, they pay a tax to pay that state match that's required for those supplemental payments. And we run those supplemental or directed payments and make sure that I keep this language correct. We run those directed payments through our managed care organizations. And currently, our hospitals and our ambulance providers are allowed to receive 100% of the average commercial rate of the services that they deliver. And we know that in conversations, there's the Medicaid fee schedule, there's the Medicare fee schedule, and then there's the average commercial rate. So we calculate those average commercial rates, and that allows those hospitals, including university hospitals, to receive approximately $5 billion extra per year to bring their reimbursement up to the average commercial rate paid by insurers. So going forward, the House Resolution 1 changes those directed payments. And for Medicaid expansion states such as Kentucky, those directed payments can be no more than 100% of the Medicare fee schedule. So this will, in essence, reduce some of the provider payments specifically to our hospitals and to our ambulance providers that will be phased in over a period of 10 years. But we anticipate, several reductions in the payments to our hospital providers and our ambulance providers over the course of 10 years in order to bring them down to 100% of the Medicare rate. Now, in non-Medicaid expansion states, they are allowed to reimburse directed payments up to 110% of the Medicare fee schedule. So again, Medicaid expansion states like Kentucky would be 100% of that Medicare fee schedule. And again, anticipate a very detrimental impact based on reduced revenues for our hospitals across Kentucky.
I know too that we have other provider taxes that are not related to hospitals, particularly the provider tax for supports for community living that's designed to help increase the reimbursement rate so that they can hire, enough folks to provide the services. Can you say a little bit more about that particular change too?
Yeah, we do believe that it will have an impact. We're still analyzing some of those impacts for that provider type. We definitely are focused right now on our hospitals and our ambulance because we do know that it's going to be a very significant change. Any reduction, and as you mentioned, Dustin, the SCL providers also paying that 10% tax. Any change in provider revenue that's going to decrease is definitely going to have a detrimental impact. And we continue to look at that SCL to see exactly how those changes will be implemented over the course of that same 10-year time frame.
Gotcha. To some degree, it seemed like Congress understood that this would have a really significant impact on hospitals, primarily rural hospitals. I know folks on the call have seen that, according to the SHEP Center, there are 35 hospitals that are most vulnerable to these types of cuts in Kentucky out of the 338 that they identified nationwide. And so to help address that, they implemented a $50 billion rural health transformation fund. The details of which are still somewhat fuzzy, but it seems like to some degree states have options on how to implement the use of those funds. Can you say a little bit about what this Kentucky is planning on doing, or at least what the planning process looks like for that fund?
Absolutely. I mean, as you said, CMS will be distributing $50 billion nationally between fiscal years 2026 to 2030. 25 billion of that, those funds are going to be equally dispersed among the states. So that's about 5 billion annually. The other 25 billion will be allocated based on rural metrics, including the percentage of the population in rural areas, number and condition of rural health facilities, and just some other rural health needs as determined by CMS. And states will have until the end of the following fiscal year to spend those funds. The objectives, of course, are to increase access to hospitals and healthcare providers in rural areas. And Kentucky is a predominantly rural state. We do know that we have some of our rural health areas. We have conditions such as heart disease, diabetes, asthma, COPD, things that need to be addressed. So overall, arching goals and objectives to improve the healthcare status of those individuals. Each state does submit one application for the Rural Health Transformation Plan, we believe, based on information that we have heard that will be through the governor's office. Again, we're still waiting on information from CMS. We were told that information would be at the end of August, but now it's looking like September before we receive additional information. But that's not stopping us from making sure that we plan ahead, because we know that we have a very, very short time frame, because applications have to be in very soon, because all funding applications and the funding has to be determined by December 31st of 2025. So that gives us a very, very short window to pull together a very comprehensive application that will allow us to draw down some of those federal funds. So on July the 29th, we did issue a letter to stakeholders requesting input on our rural health transformation priorities. Some of you on this call may have even received that letter. We would like responses no later than August 31st. we're also seeking an organization or a vendor to help pull all of this together, not just the rural health transformation, but every aspect of House Resolution 1, because we definitely need to comply with federal rules in order to receive that funding. So hopefully we will have someone on board to help us, because again, this short time frame, we're looking at, hopefully we would like to get our application submitted as soon as possible. So if you're looking at a December 31st decision date, definitely have to get that application in prior to December 31st. Our goal would be around the November 15th to December 1st range, to give plenty of time for review and consideration. So our next step, again, is just continue to have that stakeholder engagement, review feedback, and create a very good, solid application as quickly as possible to help us garner not only that first round of funding, but funding additional that may be able to come to the state. So again, just still waiting on CMS to deliver some information, some guidance on the application itself. And we do understand that the Centers for Medicare and Medicaid Innovation will actually be overseeing or administering those funds, and still waiting on guidance on what that looks like. But we, again, going back to the hospital reimbursement improvement program that we have here, those directed payments, and our hospitals and our university hospitals receiving about $5 billion a year. You can kind of see how important this money is due to the magnitude of funds that we'll be losing. But again, this hospital reimbursement improvement program is limited. It's over a 5-year period, and it's not going to make up for the funding that we would lose in our hospital systems on an ongoing basis. So very limited time funds. So we can't. What we're looking at is how we can definitely make an improvement in the health status of our individuals, but we can't look at anything that's going to need ongoing funding unless we can identify some source for that funding as we move forward.
Yeah, it seems like an important drop in the bucket. Despite the Rural Health Fund and some of the other aspects of the One Big Beautiful Bill Act, one thing that did not occur was an extension of the enhanced subsidies on the exchange. So we have close to 100,000 folks who purchase individual insurance on Connect. Many of those do so affordably, thanks to several of the improvements that were in the Inflation Reduction Act, and then the ARPA before that. And so today we have David Very with Connect to talk a little bit about what we might anticipate moving into the 2025 open enrollment for the 2026 plan year. So David, can you talk through a little bit with us about what we need to look out for and what we can anticipate moving forward?
Yes. First of all, I'll start out, I'm going to finish with this as well. Open enrollment will be, for all intents and purposes, the same as it has been in previous years. November 1st to January 15th, there's no extra $5 charge. There is still the passive renewal. Virtually everyone who was eligible is still eligible today. There are 2 salient exceptions. One is a very small number of persons. It's not a small number if it is happening to you. But if people are immigrants and they are below 100% of the federal poverty level, so literally they are making too little money, right now, current day, they are eligible for tax credits and almost always have $0 plans with very low deductibles. And effective immediately, actually in 6 days, those people will no longer be eligible for APTC going forward starting January 1st. Around 1,300 lives. We have decided that we are removing them from the passive renewal stream, so they will not be passively renewed into a full price plan and sending notification, but most assuredly that small group will be unfortunately become uninsured. That's the small changes. The big changes are happening because of OB3 or the HR1, whatever you want to call it, are down the road. So there's a lot of mud right now where people are thinking that maybe those changes apply. They do not. Everything else is exactly the same as usual as far as the mechanics of enrolling, re-enrolling, and how things are calculated. What OB3 did not do was extend permanently, or even for a year, the enhanced part of the premium tax credits. This did two things. It's doing two things right now, actually. One, for persons who make over 400% of the federal poverty level, they still can qualify for APTC for help on their premiums. Many do. We have about 6,000 or so individuals who are above that limit who purchase insurance and use tax credits to help pay for it. This will be a subsidy cliff. They will no longer be eligible at all. Still a relatively small population, but this group is going to experience the largest increase. A 60 and 62-year-old couple from Boone County or wherever, these are real people. These are not hypothetical situations. When the tax credits get sunsetted, they will see an increase in their premiums, the amount that they owe, by over $1,200 a month. So these individuals will have to choose between housing and health insurance, and will go into that horrible category we had before the Affordable Care Act of uninsurable, or they'll go to junk plans, health sharing ministries, and the like. For the rest of everyone else, the math is changing between what is considered affordable and the percentage that of their household income that they're expected to pay. And so when the math is changed back to what it was 4 years ago, it means that everyone who gets tax credits will see an increase of the amount they owe each month. Every single person. On average, people pay around $100. That the actual average is $180 per month after tax credits. That's kind of skewed high because that 400 group. So most people pay about $100 for health insurance on the exchange. Most people will see that double, at least. Compiled with that is we have gotten our insurance rates increase for next year, and they are the largest we have ever seen. The largest in recent memory, 26%, 37% for our lowest cost carrier, and 15% for the three carriers that remain. I'm saying three carriers because of this uncertainty. This is what's driving this rate increase. We have gotten word that CareSource will be leaving the marketplace entirely, and Molina is now withdrawing from 31 of their counties, leaving 11 counties that will have Anthem only, and about 20,000 people who will have to actively shop for new plans, in addition to the 10,000 or so that usually shop for plans, in addition to the scramble that will occur when people are trying to find more affordable options. I'm usually pretty optimistic, folks, but I'm being honest. This is going to be the single most challenging open enrollment the exchange has ever had. Ordinarily, we only have to deal with in a good sense, 15,000 people or so last year who are actively shopping. Everyone else, like we all do, you just stay on the same plan each year, pay a little bit more or whatever. And optimistically, half of our people will have to be searching for new plans. Realistically, it will be higher than that. So the system, and by that I don't mean our computer system, I mean the system as a whole, contact center, agents, connectors, us, are going to have to help shepherd these people through these uncertain waters. I can educate, I cannot advocate. If people can advocate, the time is now. When Congress comes back from their break, they have 30 days, however they made their own in September, to fund the government. This is really the most realistic last chance for them to change law. It will take an act of Congress. This is not a final rule, to put the enhanced tax credits back before we pass a renewal. Worst case scenario is where we're in now. Best case scenario is they change then. The most confusing case is if they take action at the end of the year. We then will be putting tax credits back and trying to get people to come back we might have to open a special enrollment or something like that. We will do everything we can. We are committed to making sure that we keep as many people enrolled in the best plan as possible. And I'll pause. I said that all in one breath, so I'm sorry. But
that was an impressive breath. Yeah, I think one of the, well, there are two sort of main things that I'm left with. One is that we have a blueprint. We had a system that worked for several years, and so for Congress to make good on their commitment to keep people covered, all they have to do is continue that same blueprint. And so I think those of us who can advocate really should reach out to our congressperson and let them know about what the impact will be. And we're primarily talking about working class and middle class folks, small business owners, and others who are going to be primarily impacted by this. I think it's also important that folks reach out to a connector if they need help navigating this new system, because there are going to, it sounds like there's going to be a lot of work on the part of folks who may have been covered by a carrier who are going to have to make new choices, or folks who may have had an APTC before who are going to have to make a quick change. I want to go ahead, David. And then
if I can just add one more thing. As we speak now, we're on the floor of the state fair, of course. And in addition to the regular kind of things that we're doing, we're signing people and whatnot. We have a value of health insurance brochure we have made to try to really impress the people that even if your rate goes up $100 a month, and that's $1,200 for the year, that's a heck of a lot cheaper than $120,000 because you need a kidney surgery.
Yeah.
So we're really trying to leverage that, and I'm asking you all for help. If there's any way that you can think of, or anything that we're not doing, we have an educational tab on our website. We've made a fact sheet that we distribute that tells the scary news, but we're not blaming the issuers. We're doing everything we can. But if there's anything that you see that we're not doing, I have rather tough skin and take criticism well. Please shout at me, and we'll do everything we can.
We have just a couple minutes left in this section, and I see Commissioner Dennis is with us. Obviously, this bill didn't just impact healthcare, it also impacted food assistance pretty significantly. And so there were just a couple of things, Commissioner Dennis, I was hoping you could touch on. One is the changes to the way the work reporting requirement in SNAP impacts SNAP participants, both in the counties that may or may not be waived anymore, and also the populations affected. And then also maybe a little bit about the anticipated cost share for the state that we're going to experience for the first time.
Well, good morning, everyone. So yes, HR 1 did make significant changes to SNAP and the work requirements. So with regards to work requirements, currently SNAP recipients who are ages currently we have an exemption for work requirements for individuals that are over the age of 55. That age increases from 55 up to age 65, and individuals with dependents are currently exempt from work requirements, and that changes to individuals with dependents under the age of 14. So those individuals will now be subject to work requirements. And it also previously, prior to HR 1, there were exemptions in place for homeless individuals, veterans, and former foster youth up to age 24. And those exemptions have been removed as well. So those individuals will now be subject to work requirements. And also, we currently have a waiver in states can apply for a waiver if their unemployment rate exceeds 10%, or basically if there is insufficient jobs within within a county or within the surrounding county to meet the demand for work eligible individuals, then you can also request a waiver. And HR 1 removed that last piece, the piece around insufficient jobs. So, and currently, Kentucky does not have any county that has 10% or more unemployment. So that our waiver will end on November the 30th. So we currently have 117 counties that are waived and exempt for work requirements, and those that waiver, like I said, ends on November the 30th. So those individuals will also be subject to work requirements. So those are the populations that will be impacted with regards to work requirements. And again, November 30th is for the 117 counties, and we're working on the pieces around implementation for the other individuals that I mentioned. And then also, with regards to the cost sharing, a couple of different things with regards to cost sharing. One, right now, the administrative cost of operating the SNAP program is 50% state and 50% federal. So that changes next year, next federal fiscal year. So next October, that goes from 50-50 to 75 state and 25% federal. So there'll be an additional cost for the state to operate our SNAP program. And then in addition to that, the following federal fiscal year, states will be, we will be looking at there will be a cost share for states if their payment error rate exceeds 6%. So right now, so again, if a state exceeds 6%, they'll either have to contribute 5%, 10%, or 15% of the cost of benefits will have to be paid by the state based on that payment error rate. So if we are below 6% or below, they will be, Kentucky would have no cost share of those benefits. But if it's above, again, it would be either 5, 10, or 15% based on the amount of what the error rate was.
Do we have any idea, essentially, how much at least the administrative cost share might be?
Approximately $66 million, an additional $66 million for that. And our payment error rate, that we're looking at that now, and we're working to address, how we can ensure that payment error rate stays low. Last federal fiscal year, it was above the 6%. It was at 9%. But currently, we are at 3% for federal, 3.7%, right under 4% for this for federal fiscal year 25. Now those reviews are always about 4 months behind, so we'd only have 2 quarters of data so far. So we do not know what our final payment error rate will be for federal fiscal year 25. And states can either use federal fiscal year 25 or 26, depending on which is, of course, lower for that first year of the cost sharing.
Well, thank you. We are unfortunately a little over time for this section. There's just so much to say about this bill and its impacts on Kentucky, and a lot of really good planning that's happening at the state level. So at this point, I'm going to hand it over to Kelly Talby to give us a little bit of an update on public health.
Sure. Thank you, Dustin, and thank you all. I think this year has proven yet again that there's strength in numbers, and the more quickly we can communicate in plain language, not just to each other, but to those we serve, is hugely important right now. I'm going to let Dr. White share her screen. She and the public health team, I believe Dr. Langfeld is joining us, possibly, hopefully, Ellen Cartmel. They have kind of a round robin ready to go here. And as you all know, public health is critically important, and these federal changes have also kind of given a little concern to some of the public health programming and any impacts there. So before we get into quality initiative, measles, and back to school talk, I want to talk about the tobacco funding and the quit lines for the state of Kentucky. But just real quick, while everyone's kind of still in this federal funding state of mind, Dr. White, when it comes to the maternal and infant early childhood home visiting, the MICV or MICV, however we say that acronym, you know, there has been a little bit of bubbling hearsay talk about some of the federal funding impacts there. Is that anything you want to speak to, just to kind of let folks know what we're up to right now when it comes to the administration of that grant funding? It does support a good deal of Kentucky's outreach, boots on the ground professionals.
Yes, and thank you so much, Kelly. I checked this morning with yesterday with our team that lead the McV, and that program is not being cut at this time. So we are very pleased to tell you that today. As you know, the big bill changes things as we every day. It's kind of like during COVID, when every day something else new and different was happening. But as I heard Dr. Langfeld say this morning, chaos doesn't have to mean breakdown. Chaos means opportunities. So we are fortunate that we're not going to have that that problem with the McV grant right now.
That's really great to hear. I know you all have heard from folks. I've heard from folks. I typically send them to you anytime I'm like, uh-oh, what's happening? You know, I mean, that impacts even hands administration in part. So it's a hugely important element of our funding. So it's really good to know no direct impact there at this time. So I'm gonna let you take it away. I know you and Ellen have kind of a tag team here to speak to a few things. And then I'll come back here in just a second.
Okay, well, thank you all so much for having us here today. We've got a lot of slides, so we're going to go really quickly. And most of the slides, you will get these at the end of the meeting. So I put some slides in, not that I'm going to read every word, but I want you to have that to go back to. And one of those slides is a slide that I forget to do, and that is what Department for Public Health does. That column on the right just shows you all the divisions are in the middle. Those are some of our programs, and even those break down into other really important things that we do in the Department for Public Health. So that's for you to look at later. We're going to go right now to Ellen Cartmell, who's our new Chief of Staff at the Department for Public Health, and she's going to talk to you about tobacco and smoking cessation, which we know that kills 500,000 people every year in the United States. And if we could just do what Ellen tells us to do, we'd all be healthier. So I'm going to turn it over to Ellen.
Thank you, Dr. White. Dr. White and I.
What is this?
I think where you all are in close physical proximity, one of you all will need to disconnect from audio.
We are okay. Can you all hear me now? We're just
Yes.
going to do it this way. So Dr. White and I are sitting here side by side. We are at the Preparedness Summit in Kentucky. Dr. Langfeld, or in Lexington. Dr. Langfeld is here as well. So we're all doing double duty, but I wanted to make sure to take time to talk to you all, as Dr. White said, about the quit line. So we talk a lot about how high the smoking rate is in Kentucky, but what I don't think we talk about enough is how many Kentucky adults who smoke say they want to quit. That's almost 9 in 10. What is a shame about that, however, is that we have some really wonderful resources to help people quit. And there we go. And unfortunately, most people who smoke in Kentucky don't know about them. So I wanted to make sure to talk about 1-800-QUIT-NOW, which goes by 2 names here in Kentucky. And I generally refer to them as Kentucky's tobacco quit lines, but they are Quit Now Kentucky and My Life, My Quit. So both of these offer 5 free, no cost, confidential coaching for anybody who wants to quit any kind of tobacco product. So it could be cigarettes, it could be vapes, it could be dip, it could be hookah. If you know somebody who lives in Kentucky who wants to quit, no matter what age they are, this is a free service that we are able to offer them. Really, the main difference between them is that My Life, My Quit is tailored for people who are 17 and younger. We know that they have some different needs from adults when it comes to quitting. And then one thing that I also always really like to highlight is that Quit Now Kentucky doubles your chances of quitting smoking successfully. So My Life, My Quit may do that as well, but because it's new, we're not as sure. But Quit Now Kentucky has been around for over 20 years now, I believe, and we do know that it is quite effective in helping quit. So one of the other things that's extremely helpful and allowing people to be able to quit successfully, as we know they want to do, is equipping them with nicotine replacement therapy, also shown to double a person's chances of quitting successfully. So Quit Now Kentucky provides free nicotine replacement therapy to many people, but I also wanted to draw attention to the fact that there is a new statute in Kentucky that says that all public and private health insurance plans do need to cover nicotine replacement therapy with no copay. So if you know somebody who wants to quit, we can get them free nicotine replacement therapy, either through their insurance, or if they don't have insurance or they're enrolled in Medicare, then through the Quit line. We also offer special services, and this is one of the key highlights that I want to talk about today, special services for specific populations. We know that people with behavioral health diagnoses like depression, anxiety, PTSD, they smoke 40% of the cigarettes in the country, and it can be much harder for them to quit. So we offer them 7 calls instead of 5, and they are guaranteed that free nicotine replacement therapy. We also have special services for women or callers who are pregnant or who are immediately postpartum. They can get incentives for completing those calls because we know how difficult it can be to quit, how important it is to quit during pregnancy. And then we also have some other services. The reason that I wanted to talk about these today is because while we are absolutely committed at the Department for Public Health to continuing offering this service, it is currently funded by state funding and by federal funding that is at risk. And it appears at this time, anything could change, but it does appear at this time as though that federal funding source may go away. And if that happens, a lot of the services on this screen, on this slide in particular, will not be available anymore, likely. So no cuts have been made yet. We are hoping to not have to make any cuts for the next couple of months, but we really want to draw attention to everybody's to these services now while we have the funding to sustain them. And so on that note, I just have one more slide, I think, which is letting everybody know that they can refer people to the Quit line. They can do this through quitnowkentucky.org, mylifemyquit.com. Those are our 2 websites that I can put in the chat. But I also want to flag that if you are a community health worker, if you're a social worker, if you're somebody who might not consider yourself a traditional healthcare provider, you can still refer. You'll just go to that slide and you'll click that you are not a HIPAA covered entity. So please refer people to these services. Let's take advantage of them while they are still at their full capacity. And let's also hope that they're able to stay at full capacity. So my last slide is just how to get more information. And with that, I'll give it back over to Dr. White.
Thank you so much, Ellen. And before we segue into some other public health updates, folks, please keep in mind, especially through your health departments, should changes happen to our tobacco cessation programs, our quit lines and funding streams, please keep that previous screen, the tobacco-free contact, quick at hand, because that is really where folks who do seek out assistance go to first most often. And so as things change, we will try to quickly get information out to you all on what the new rules and accessibility options will be. But that will be a very important connection for you all to maintain in the coming weeks and months. Dr. White?
So like I said, we'll make sure that y'all have these slides that you're able to go to. So I'm going to go through some specific things that I was asked. These are 3 websites. These slides are live. I finally figured out how I can make a live link. I'm extremely proud of myself as a digital dinosaur, but those are the links. And then I want to show you what those links look like. I was asked about measles. I was asked about influenza. And our vaccinations. And so I just wanted to take you to a couple of pages. You've seen this page before. Here's the link also on the left-hand side of your screen. This is what you will find when you get there. And as you scroll down that page, so that this is the top of the page, the next thing down, there's all kinds of tools here that you can get for back to school, for vaccinations. Well, I'll just go to what the next slide looks like because I believe I took some screenshots of them. So this is the outreach toolkit that we're getting to all of our school nurses. So everybody's got right there what they need. And you can go and you can click on this. This is a screenshot, but this would be live. It'll take you to some social media graphics, some flyers, all of the kinds of things that you see on this page. If you click that will get you to the help that you're going to need as you're trying to do vaccinations back to school. Also, this one is another resource. It's on that right-hand page of the immunization page I showed you earlier. These are, I love the coloring sheets, you know, so you've got like a coloring book for kids for them to learn about vaccination, stickers, all different kinds of resources on this one page. And as those resources get updated, this gets updated. So you will automatically have everything that's the latest and greatest in helping you get our children immunized. Y'all all know that during COVID, our immunization rates went down. You all know that we are in a culture right now that's also threatening our immunization rates. Anything that any of us can do to increase immunization rates with our children is vital to the future of our little Kentuckians. This is a slide about measles. Right now, and this was just updated. Actually, this was updated Monday. I took this screenshot last week because I was trying to get these slides to Kelly. This is updated every Monday and Thursday. Fortunately, there's no new updates since the 11th. So this tells you what the talking points that Lee Hundley, our vaccine preventable disease epi manager, sent me. So we have had a total of 14 cases of measles. This is the last one that was announced, was the 28th. We know that there's a 10 to 14 day cycle between exposure and actually having measles. So we're very hopeful that we may have this behind us. I won't go through and read this whole page to you. Go to that link and it will tell you everything that we do know about the measles. The next slide, you've seen this slide before also. This is Cover Your Cough KY. If you, whatever you Bing, you Google, whatever your search engine of choice is, if you just type in Cover Your Cough KY, it will take you to this page. Just looking, this is our latest bird flu alert. And it says we have no bird flu in Kentucky. But so this is updated alerts. This page, if you scroll down again, you're going to see this. If you go to that, what I've circled, the dashboard, and you go to all conditions, it'll pop up that's all the nerdy epidemiology words that you don't need to care about. This is the conditions, and this is our last flu or our last immunization or disease, respiratory disease season. So our season starts in October and goes through the end of August. So this is our last season. This tells you all respiratory illnesses. This line is COVID. This is flu. There's COVID, and then there's RSV. You can go over here and do this drop down box, any flu season you want to look at. You can look at all of these or just one or two of the conditions of the different kinds of infections. You can look by regions. You can look by age groups. You can make yourself a cup of tea and really nerd out on this if you want to. But this is something you're going to want to know as school's starting, and you'll start seeing updates on this map every starting in October, after the first week in October. Dr. Langfeld was here and just got called out to talk to the secretary. So the secretary trumps us because that's his boss. So he had already given me these slides. There's a lot of information in these next 4 slides. I'm going to give you the nutshell of what this project is. This is Dr. Langfeld's baby. This is the quality improvement project he was brought to Kentucky to do. He was the medical director for Medicaid when I first started in the cabinet, and he has then left that role and has spent many years working in quality improvement in big systems across the country, working for an advisory group. All of these things that you're going to look at and read right here, he sums it up, and he just did it this morning to the preparedness meeting. If you think about the heart has 2 to 3 billion cells, I think he said this morning, in it. And it is an organ that works together and provides blood and oxygen to our whole entire body to make it work. And it's that synchronization that works. So you can look at an EKG and you can see the bumpy things. That's when the heart is pumping and getting that vital blood to the whole organ. Many of you, unfortunately, have seen the EKG tracing for ventral fibrillation. Ventral fibrillation, the cells are working. They may even be working well. They may be working strongly. They may be doing everything they're supposed to do. But if they are not in sync, then that entity does not get the oxygen that they need, and it doesn't function. So Kentucky Health Forward is an effort to get us out of ventricular fibrillation and back into a regular sinus rhythm where we're all strong and we're all rowing in the same direction, as Dr. Rice Leach used to say. So this slide is a very busy slide, but I kept it in. He's the boss. You know, I'm not going to take slides out, but this is the part I wanted you to look at. And I don't know if you can see my arrow, but we need to refine our focus, collaborative priorities, and then we're going to have the collective impact that we want. This is a framework of what he's wanting to do here in our cabinet. This is not just public health. This is the whole cabinet. I love the way that it looks just like the public health PDSA cycle. You plan it, you do it, you analyze how you did it, and then you put it out there for everybody to do. So that's another thing that you can look at in more detail. But this is the thing that he also says that I think really is the essence of what this is trying to do. Right now, we are going forward and looking in our rearview mirror, which is a very hard way to drive. We are looking at lagging indicators. We are looking at reports. We're looking at report cards. We're looking at data that we have. And sometimes those data are years old. What we're not looking at is looking at our leading indicators. How can we look at healthcare and the health of our Kentuckians in the GPS? And an example is, we know that for better health outcomes for maternal child health, we need attending more visits, more antenatal visits, attending postpartum visits, not smoking in pregnancy. Those are three that just immediately come to mind. We know that with a Hands family, they go to more appointments, they keep their postpartum appointments, they get their vaccinations, they do all those leading indicators for better outcome. So knowing that, then we need to push people into Hands, because we know that's going to go to our leading indicators to give us our better outlook. So GPS versus rearview mirror. So that sums up Dr. Langfeld's life's work in about 3 minutes. But we are very interested in answering questions. We need to get a time when he can come and just talk about that. This was just happened not to be the day. So you got the Connie White interpretation of Dr. Langfeld's work. Happy to do questions. I know we're out of time, but we will get those slides to you. Back to you, Kelly.
Thank you so much. The public health team always does a phenomenal job packing in a tremendous amount of tools and resources and programmatic updates for us all. And we really, really appreciate you. And I love that analogy. You know, the more targeted and upstream our interventions can become in real terms, when it comes where the rubber meets the road and policy implementation, the better. The greatest wealth is health, right? And when it comes to improving our immunization uptake, having those maybe awkward at times conversations, being a little more leaned in than we have in the past with parents and families, so that they understand the importance and the value of protecting their children right now. I hope everyone uses these tools, and we really look forward to, as the quality initiative continues to grow some teeth. Today was kind of our big picture, high level, here's what's about to happen. But as it grows and begins to have more details to share, we really look forward to hearing those updates.
And it started in the cabinet. As we get our act together, then we're going out and we're going to be reaching out to everyone on this call to make this work.
Thank you. I am going to hand it over to Dr. Sheila Schuster to transition us over to a RISE update with our behavioral health team at the cabinet.
Thank you very much, Kelly, and thanks to our public health colleagues. I'm Dr. Sheila Schuster. I'm a psychologist, and I head up the Advocacy Action Network, which is the Kentucky Mental Health Coalition and the 874K Disabilities Coalition. And I'm very excited about our topic. We have been working for probably the last 5 years very intensely to focus particular sources and help for our people who have severe mental illness or SMI. Those are people with schizophrenia, schizoaffective disorder, bipolar disorder, major depression. And we are about ready. Well, we are in the process of implementing what is called the RISE initiative. And I'm very pleased to introduce Tanya Dickinson, who is in charge of special projects at the Department for Behavioral Health, Developmental and Intellectual Disabilities. So I'm going to let you take it away, Tanya, and thank you so much for being here today.
Great. Thank you all for having me. Much appreciated. Let me see if I can share my screen and we'll see how my tech skills are this morning.
I think Alex has you set up to do that.
Okay, let's see. Come along, come along. There it is. Let's see if we can get that to open and share. All right, let's put this on a slideshow. I'll try to do this. Try to do a fairly short version because I know everybody's pressed for time this morning. And thank you for the introduction, Sheila. I'm not in charge of special projects, but I do a lot of special projects.
Okay.
Nobody figured out what my job description is other than you could work on that. So, but currently the special project that I'm working on for the department is one that is near and dear to lots of folks. It's the 1959 RISE initiative. It's an amendment to the state Medicaid plan. For those of you who like it inside baseball, it's kind of like a waiver, like a 1915C, but it's different because it's a 1915I. Operationally, the biggest difference is there is not a quota or a cap on the number of individuals that we can serve. We expect to serve approximately 5,000 individuals a year, but it's just a change in an individual's Medicaid coverage. They'll go from if they're being served by an MCO, they'll go to a fee for service system for the providers to get their billing reimbursed, but that's really how that works. It's a joint initiative of the Department for Medicaid Services and Department for Behavioral Health, Developmental and Intellectual Disabilities, otherwise known as BDID, and focuses on helping individuals rise above their challenges through services that promote recovery, independence, support, and engagement, or RISE, in the community. The quick overview of the program is what I can tell you about today, and we're going to be making various announcements and various developments, and we're happy to come chat with your group. And let me see if I can make that smaller so you can see my cute little billboard.
Yeah, we can see the billboard.
Oh, you can? Okay, great.
Yeah.
All right. And I have changed my view, so if you're looking at a billboard, then that's the high points of the 1959 RISE initiative. Like I say, it's an amendment to the state plan and similar to waivers, but it operates a little different. But if you've got the concept from waivers, you'll understand what this is. It's a targeted program with a targeted population. And so far we are at the beginning stages of implementing this. Really, we began accepting provider applications for certification to provide services on July 1, and we'll announce a date to start enrolling individuals into the program in the near future. And you can visit our webpage to read a whole lot more about it and it's the services and the details of how to become a provider and what the participant experience is and that sort of thing. And since I can't chat and talk at the same time, when I'm done with this PowerPoint, then I'll add in a number of links for you in the chat box where you can get to the web page and some dedicated emails and things like that. Let's see, currently we've got about 90 plus folks in our application process. They've at least begun the application process to become a certified provider. And what the program will offer is 10 services designed specifically for this population. They're essential home and community-based support services, or HCBS, and there's 10 of them. Assistive technology, things, like medication reminders or calendaring, that sort of thing. Case management. Every participant will have a case manager who will then help them access all the remainder of the services. There's housing and tenancy supports, in-home independent living supports, medication management, planned respite for caregivers, supervised residential care, supported education and employment, and transportation. And don't worry, that list is all over the web page. There is no quiz on this this Zoom meeting, so you can go there and there's lots more details about what's required of the providers for each of those services, as well as what the need levels of individuals must be to access those services. I should say that participants receiving any of the housing services must be homeless, at risk of homelessness, formerly homeless within the prior 24 months, or now residing in HUD-assisted housing, and have a history of frequent nursing home or inpatient stays. And they can be preparing to exit an institutional setting. And these services can all be received alongside other complementary programs like ACT or AOT, assisted outpatient treatment, as long as they aren't duplicative. The services are targeted to individuals who are 18 and over with serious mental illness or with a serious mental illness and a co-occurring substance use disorder. And we've had inquiries from any number of folks who are interested in making referrals as soon as those become available when we've got that part of the program opened up. Hospitals can come from families, can come from guardians, just any number of entities can make that referral. The real quick and dirty, how does a provider get to be certified? They go to the website, go through the kind of really basic orientation there and follow the links to some online orientation. And when you get to that first orientation completed online, then you've got a certification packet that's attached there. You know, we're government, we got to have forms. We've got to see everybody's documentation and policies and procedures and things like that. It's very similar to the 1915C process, and we've had a number of inquiries from folks who are 1915C providers. We think we'll be getting a lot of our providers from that pool. They'll go through a review process with our quality assurance technical assistance staff, and then we'll be certified to provide one or more of those 10 services. And then their staff have a required training curriculum that they'll need to go through. All of this is through an online system managed by Medicaid called Adobe Learning Management, which a lot of folks may already be in if they're providing similar services. And those can be, some of them are completed within 6 months and prior to working independently with individuals, participants, and the remainder are to be completed within 6 months. Then we have some targeted and ongoing training that provider staff will be required to attend to enhance their case management skills, motivational interviewing, all the things that you need to develop to work with this particular population. That's how a provider gets to be a provider for 1959. A participant or a potential participant would be referred to the program by again, any one of those sources, or could refer themselves. They can access us through the web page, through some dedicated email box, or by giving us an old-fashioned phone call, and we'll get them to a screener to make sure that they are qualified for the service, just at the most basic level, that they have a serious mental illness diagnosis and that they are Medicaid eligible. Once that quick and basic screening is taken care of, then the individual is referred to an assessor who is a BDID staff member. And then they will spend a number of hours with that individual going through an assessment process. It's through a company, it's a standardized instrument through a company called INTERAI, INTERAI. And they'll go through that, determine functional areas that need assistance. What does the individual qualify for in terms of services? And then once that review is complete, they'll refer the individual to a case manager that the individual gets to select from a list of approved providers. And then the case manager in turn will help them develop a person-centered service plan and select other providers for those other 9 services to get that whole system in operation for that individual. The case manager is sort of the hub of the wheel. The case manager and the participant together, this is all participant directed. They may choose their providers. They may choose to not participate in a recommended service. It's not compulsory in keeping with the Medicaid requirements. That's reviewed. The personal service plan is reviewed every year, as well as the assessment to make sure that the individual still qualifies and is still receiving appropriate services, etc. And I should say one other thing about the assessment. It can begin while an individual is still within a facility. If they're, as part of the release planning for someone who's in a psychiatric hospital, for instance, but it must be completed once that individual has returned to the community, to keep in line with our Medicaid requirements. There's a couple of really snazzy graphics on the webpage that show the provider journey, and along a cute little path of Kentucky scenery. And there's also one that shows the participant's journey. There is included links for folks to refer to. Let's see if we can go to the next page, the last page. Did that slide advance? Because I managed to change.
I don't think it's showing anything different from the billboard slide.
All right, well, let me see what I've done.
But we do just have a couple more minutes for this.
Yeah.
I am just about done, so we'll go to the very last. There we are, and it's okay.
And we will be sending these slides out afterwards.
Those are the basic stats. 90 plus have registered for the application process. We've got staff in place and operating. The newest announcement for us is to help encourage providers get through the application process. We're going to set up office hours so that folks can, we'll just be hanging out online, and anybody who's a provider wanting to get into the process or complete an application, they can join us. It'll starting the week of September 8th, and we will make sure that we're available for folks to just sit and chat and provide them with whatever they need. If it's something more in depth that they need, we can take it offline and do that elsewhere. We had a great webinar with folks recently, and are now starting to do follow-up meetings with provider groups. And that's really the status of what we've got currently. I'll put those links in the chat.
We appreciate that. Yeah, we appreciate that, Tanya. And if you could put the links in the chat. I'm sorry to rush us, but I know we're running out of time. So thank you very much. It's a very, very exciting program. And I'm going to turn it over to Emily Beauregard at this point. Thank you, Tanya.
Yeah, thank you, Tanya and Sheila. And, we don't have as many bright spots as we would like to right now in our health policy landscape and some of the programs and services that we're able to encourage folks to take advantage of and participate in. But the RISE waiver is certainly one of them. And there's also something else on the horizon that is very exciting as a development. And Deputy Commissioner Veronica Judy Cecil is joining us. Sorry to get your name a little mixed up there, Veronica.
It's a long name. That's okay.
Get it out of order for some reason. But I wanted to really just bring some attention to the work being done to expand our Medicaid advisory structure with new MAC members, Medicaid Advisory Council, and brand new, for the first time, Beneficiary Advisory Council. And if you could just take a couple of minutes to talk about how this is developing and what the rollout plan is, and maybe some of the specific ways in which beneficiaries will have more opportunity to have input and sort of that direct working relationship with DMS.
Thank you, Emily. I appreciate the opportunity to be here today to talk about it. We are very excited about our new Beneficiary Advisory Council. A couple of states had already had a Beneficiary Advisory Council, but it is new to Kentucky. It is due to a federal rule that changed the federal regulation about advisory committees and councils. And we were required to comply by July 9th. And I'm happy to say that we met that implementation date. For those of you, I did put in the chat the link to our brand new Medicaid Advisory Committee website and our Beneficiary Advisory Council website. On those websites are the new appointees for both of those advisory committees. So please feel free to go out and take a look at them, as well as their terms. For the Beneficiary Advisory Council, we're thrilled to have a dedicated group and space for that member voice for us to interact with. The council is made up of 15 people, and that includes both current and former Medicaid members, as well as families, representation from families, caregivers, and guardians. Our new appointees come from across the state and across the different populations. So we have the fee-for-service, the home and community-based waivers represented, and the managed care population represented. So we're really thrilled to have that diversity in our group as well. The BAC will be, we're working on an orientation for both the BAC and the MAC, and we'll be providing that to the new members of both those groups in the next probably month, and working on scheduling the first meeting for both groups, hopefully towards the end of September. But those updates will be provided as we do confirm those first meetings. Couple of things to note. So the Beneficiary Advisory Council, those meetings can remain private. They are not subject to open meetings. The federal law is what makes those be private if those members decide to choose to do that. It is up to the members to make that decision. So just note that those meetings may not be open to the public. The other couple of things for the BAC is that we're really looking to engage them in helping us understand the member voice for all the federal and state changes as we move forward. We've talked already about HR 1 at the federal level, and cost sharing, and just a lot of the community engagement work requirements, a lot of things that we really look forward to this body of members to give us an idea of what they think, how they're affected, what we can do to better implement with the member in mind. So looking forward to that engagement, that robust engagement with those folks. A couple of other things to note about the MAC. First of all, there's no change to the technical advisory committee. So for those of you who may be familiar, we have 17 technical advisory committees, and they represent the various populations and provider types in Medicaid. So nothing is changing with that. But the Medicaid Advisory Committee has changed. It's got new membership. We did maintain the membership from the old advisory council that's in state statute, and then we added in members that were required by the federal rule. So you're going to see a shift in the membership. It's really an addition of members, primarily representing, there's a managed care organization representative that has to be on it based on the federal rule. And then we have 7 members from the Beneficiary Advisory Council that will be on the MAC. There is a requirement for the MAC to have a certain percentage of the Beneficiary Advisory Council members on it. So it's grown. It's going to be a little larger. A couple of other things just to note, and that is that the BAC is required to meet before the MAC. So we have to make sure that whatever the schedule meeting, the meeting schedules for the MAC, we have a BAC meeting prior to that. And that is so that the department can support the MAC members that are on the MAC, the BAC members that are on the MAC, and make sure they're prepared. Do they have questions? What can we do to support them? And, you know, have a lot of conversation about the subject matters on the agenda, and any questions they may have. So there'll be a lot of interaction with the BAC prior to that MAC meeting to get them prepared. I'm trying to think, I think maybe the only other two changes, there is an annual report that's required by the MAC now. So we'll be working on that with the MAC for that annual report. And then at the end of the meeting, there is a requirement for public comment. So the MAC meetings will be structured to allow some time at the end of the agenda to allow for anyone from the public to come and make comment. I think those are the kind of the highlights, a really quick summary of what we're looking forward to.
Yeah, thank you, Veronica. This is, like I said, it's really exciting to have this opportunity to have more consumer engagement, and particularly in this time when so much is changing and could really impact people's access to Medicaid, whether eligibility or enrollment. So we're looking forward to getting started, and please, you know, take advantage of that public comment period at the end of MAC meetings. We'll make sure to send out information about the MAC and the BAC as these things develop, so that you can be engaged. And with that, I'm going to turn it over to Priscilla to continue this conversation about Medicaid and talk about child renewals.
Thank you. Well, I'm very excited to get started to talk about child renewals. We've talked about this in the past, and just as a reminder, child renewals restarted for the first time in 5 years, maybe more, just last month. And so this is new for a lot of Medicaid members, a lot of parents who have never had to go through this process before. And so very excited to hear how that first month went, and to help spread information. So if you're working with any children or families, make sure that they know child renewals are back, and make sure that they engage with the state. So with that, I'm going to turn it over back to Senior Deputy Commissioner Veronica Judy Cecil to give us a quick update.
Thank you, Priscilla. And these slides will be shared. And so there's a couple I might kind of quickly move through. We always try to give the overview of all renewals and what that trend looks like. And as you see here, we really kind of hit just staying constant, but now a little bit of a dip in August. And some of that has to do with the fact that we don't have our public health emergency unwinding flexibilities anymore. The child renewal extension was one of those. And so we were able to maintain that child's coverage you know, during a renewal, but now starting with July, that changed. This again is an overall view of all renewals, and we've got some slides specific to child renewals, but we still had a fairly high, over 80% automatic renewal rate, and you'll hear it called passive or ex parte. And what that means is we were able to go out and ping all the databases that's required and get information and verify it, and just go ahead and redetermine that person automatically, so they had to take no action. That's what you see when we talk about passive or ex parte. The approval number here includes ex parte and passive, but we really had a large number that were the result of that automatic renewal. And then terminations, you see 4,944 with 412 pending. This is a snapshot by age. We looking at just that, it might be a little hard to see, but just looking at just the child, so the 0 to 6 and the 7 to 18 age groups, there were 8,423 approved. And unfortunately, there were 950 terminations of children. That bothers us. We don't want to see any children terminated inappropriately. We'll get into how they were terminated in just a minute, but this is just a snapshot by age that we're going to start sharing now with the interest in child renewal specifically. We're going to start using this every month to track it on our monthly virtual meetings, which please join us on Thursday, and we'll put that notice in the chat. So moving to children specifically, what you're seeing here is there are different types. So I mentioned that passive automatic renewal, that's on the far right here. And it says passive with no RFI, meaning we were able to go out, ping the databases, get them renewed automatically, didn't need any other information. And as you can see here, a large number of those children were able to be renewed that way. In the middle bucket there is folks that we went out and pinged, we still needed an RFI, a request for information, to get a little bit more information to complete that redetermination. And there you can see in the blue is who we were able to approve through that process. And in the orange are the ones that were determined ineligible. And then that far right bucket is those who had to go through an active determination. So we were not able to even go out and passively renew because of their situation. And they were put into an active, which means they were sent a renewal notice. They said there was required action on their part. And as you can see, in the active bucket, we had 379 who were approved, meaning they returned the information, we could determine them eligible, and 366 that were terminated. So anticipated renewal count was another request, and this forecasts the caseload over the next 12 months is what you're looking here. The blue line is all cases. The orange line is just children, cases with children. So you can kind of see the difference there. As typical, we try to keep in the months with a holiday, November and December, we try to keep the caseloads low, because workers taking off time, we have less days in the month to process renewals. So that's why you see a little bit lower number during those months. So just a reminder to folks, currently, they're subject to change with HR 1. Currently, every member is renewed. That's subject to a renewal every 12 months. We do have some members that are categorically eligible for Medicaid, and that includes foster children. They don't go through an annual renewal, but most of our population goes through an annual renewal. We really strive to make sure members understand, and if you all can help spread the word to keep their information updated with us. If we can't contact them, they don't know they're going through a renewal. So making sure we have the most current address, email addresses are great. Phone numbers are amazing, because then we can call them if they're in an active renewal. We do send, the way the renewal process works is the first of the month prior to the month of renewal, we do that passive automatic trying to renew folks. If we can't, and it drops down that we have to send them a renewal notice that requires action on their part, that is sent at least 45 days prior to the due date. Their due date is always the last day of the month of their renewal. And then we send a reminder 15 days. So our system goes out and looks, this person hasn't responded. We'll send another reminder 15 days prior to that. So members can check their renewal month. It's on Kentucky HealthNet. It's on Connect. If they have a self-service portal, they can call the Connect hotline and ask when their renewal month is. And providers have access to member renewal dates. It's in Kentucky HealthNet. And then, we always just encourage members to, as soon as they get that notice, to send the information in. If they don't, and they get terminated for lack of response, if they come back in within 90 days and submit information, they can, the DCBS can just reactivate the case. They don't have to, all we need is that information that's missing. They don't have to provide anything else. If it's outside the 90 days, it is called reapply or reapplication. But we do try to use the information that we have available. It just all has to be re-verified at that point. So keep that in mind. I know we're out of time, so just letting you know, there are various ways that we're conducting outreach. Our managed care organizations actually send members letters. They call and reach out to members who are going through an active renewal. We share that information with the MCO, and the MCO reaches out to those members too. So members are getting it from various sources, and sometimes probably get tired of hearing from everyone. But we think it's important that we provide that significant outreach. And of course, our connectors are amazing. I know there's several of those on today. We appreciate that. For children specifically, we also, as we started to gear up for child renewal, we have been working with the Friskies in the schools, and we're going to continue that. We're going to be we have attended, and we're going to be continuing going to school events. We did a lot of back to school events, trying to remind parents that children are going to have to go through that renewal. Lots of information out on our website that I shared, the Medicaid renewals website, communications for all members. And then we have very tailored communication for the children and a children toolkit, renewal toolkit that I recommend that you guys reach out to. So that is a very short and quick discussion about renewals.
Thank you so much for all of that great information. And I appreciate you running through it so very quickly. I do want to also shout out a reminder that Emily put in the chat. Income limits for children are much higher than for adults. So if you're working with any families, and you think and you're not sure, just fill out the application. It is much easier to just fill out the application, submit the information, and let the state make the determination about whether or not that those people, they're eligible or not. You don't have to decide that for yourself. And if you need any help, connectors are incredible. There are free resources available in all 120 counties, and they are happy to help and walk through that entire process for families and children. So if you need any help, you can find connectors on the Connect website. It's super important that folks know that that resource is available. We've done listening sessions for the last 3 years, and one of the things that we've heard most from individuals is that the single thing that helped them through that process most was the availability of a connector to walk them through. So if you need any help, definitely reach out to them. I have lots of questions that I would love to go into with you, but just in the interest of time, thank you so much for covering that. And there is also the consumer attack meeting. That's this afternoon. That's 1 o'clock, I believe. And that's a public meeting. There will also be an update about child renewals there. And then the state's, the DMS stakeholder meeting is this Thursday at 11 a.m. And they always do a fantastic job walking through that data a little bit more in depth. So 2 other opportunities to also get more information about this. And so with that, I will turn it back over to Emily to close this out.
Well, thank you, Priscilla and Veronica, and all of our speakers today. This has been such good information, really helpful, very timely. I will not keep everyone. Just know that we will be sending out follow-up information, and please continue to engage with us in future webinars and meetings, and we'll continue to get this information out as we have it. So appreciate seeing you all, and have a good day.